Good day, everybody. Today I will present about registries and real-life data in uveal melanoma. It's an overview of registries which have been published or ongoing and real-life data on especially treatment outcomes in uveal melanoma. These are my disclosures. Registries or real-life data in uveal melanoma are done in a rare tumor, and it has a low incidence of 0.6 to 0.7 new patients per year in 100,000 patients. The primary treatment of the uveal melanoma is aimed at cure, which can be radiotherapy by ruthenium irradiation or proton beam irradiation or enucleation, and there are substantial differences with skin melanoma. Uveal melanomas have GNA11 or GNAQ mutations, no BRAF mutations, a low mutational load, and low PD-L1 expression. Metastases are seen within 5 years in 30% of the patients, within 15 years in 50% of the patients, and metastases most often go to the liver, up to 90% of the patients, to the lungs in up to 30% of the patients, the bones and the skin, and often the metastases are within the liver only. There's a limited prognosis in case of metastasized disease, and in a publication of Koya et al. In 2019, 29 phase 2 studies were reviewed, and what they saw was a median survival of 10 months, which is not very much longer than the 7 to 8 months which was seen if you don't treat patients. The goals of real-life registries are to get standardized information and feedback about care quality, to provide patients what to expect of the outcome of treatments in their specific situation, real-life and real-world data, and enables medical specialists to refine their services and improve their healthcare systems. And concerning innovative and often expensive new therapies, monitoring treatment strategies and their effectiveness in clinical practice can help to regulate healthcare costs. Well, patient registries are data systems for prospective collection of clinical data to assess specific outcomes. There are several registries like administrative, linked and disease, procedure or pathology or product specific registries. A registry study is generally considered a level 2 or 3 evidence, and a registry based RCT may change this paradigm. In contrast to a registry, a database is an electronic set of data that is neither systemized nor organized for explicit use for answering health-related questions. The strengths of registries are the volume of data available, diversity of included participants, efficient enrollment and data collection. The limitations of registries are variable quality of data, a lack of active follow-up, a lack of detail in the data collected. And what I did was a search for registries and databases in and what I saw was nationwide or region-wide or city-based registries, hospital-based registries, international registries and databases. I found epidemiological or treatment-based registries, government, physician, patient, pharma-driven registries, and the disclaimer of my talk is that the overview is not complete. And which data or data sets are available, that differs between the registries and data sets. You can either have a large data set on the primary tumor, but often you see less information on the metastasized setting, and we don't know often when patient got their metastasis and how they were treated. As first example, you see here a nationwide registry of the Netherlands, which concerns time trends on and survival of over 5,000 patients in the Netherlands over 30 years. The National Cancer Registry in the Netherlands covers every cancer patient newly diagnosed in the Netherlands, and from the date from primary tumor determination, the follow-up is determined. The information of the primary tumor is collected, but not always from when and if metastasis occurred and how they were treated. Well, in this study we started with 5,113 patients with tumors, and we ended up with 5,036 patients being eligible for this analysis. And what you see on the right is the incidence of new patients per year, and you see a slight decrease, which can mainly be explained by the fact that we saw more early stage tumors in recent years, which is probably due to better diagnostic procedures. What we saw also is that the overall survival and cancer-specific survival are quite bad for these kind of patients, and we compared the recent period with a period before, so the first 15 years versus the last 15 years, and that's why the follow-up period of the last 15 years is shorter, but we did not see improvement of survival, which we know from daily clinical practice that the prognosis of patients is still laying behind if you compare it to skin melanoma. Then here you see a National Registry of New Zealand, in which there was a 21-year review of the National Cancer Registry of New Zealand. And here you see the baseline characteristics. They had 703 patients in 20 years time, and sex, ethnicity, melanoma site, morphology, disease extent, TNM stage were collected. And what you saw is that the incidence was quite stable if you see the curves with low numbers per year. The overall survival on the right shows the uveal melanoma specific mortality and all-cause mortality. We see that the specific mortality is somewhat higher than the all-cause mortality, which is logical because patients can die from other causes. Here you see a nation, a region, a citywide registry in a publication of 2007 on the incidence of in Europe, and 6,673 patients from 33 cancer registries in 16 European countries, regions and cities were collected. So it was quite different. In some countries it was nationwide, in some countries it was region-wide, and in some countries it was city. But you see here together over 6,000 patients collected. And what you saw here is also that the incidence did not really differ between the years, also not between females and males. Then a partly nationwide registry on epidemiological trends in uveal melanoma, and these were cases from the SEER database, which covered 26% of the overall USA populations. And what you see here is the baseline characteristics, and on the right side the survival in months. And on the next slide it is shown the prognostic factors for survival of and we know that already from the clinic, but it's good to see those proven prognostic factors here, which is histology, T-stage and age at diagnosis. And then we go on to a hospital-based database of uveal melanoma in Brazil, and these were data of 321 hospitals from 2000 to 2016, and they looked at cutaneous, uveal, and mucosal melanoma. And what they saw was that the incidences of uveal and cutaneous and mucosal melanoma were quite stable, with, of course, more cases of cutaneous melanoma and less of uveal and mucosal melanoma, since those are the rare melanomas in the field. Then a European registry, which has run for 3 years now, the starter, and it was started from Eurocan on and was a collaboration between two associated partners in Milan and in France. Milan in Italy and in France. And this project is basically shown here. It was started in 2020 and ran for 3 years, and at the moment it continued as a project for the G1 and G7 groups in Eurocan, which are the groups for sarcoma and head and neck cancer. And I think it's good that we have this kind of registries, because in rare tumors you need more data from more countries to have a larger database to make analysis of, and this kind of initiatives are very important to get enough patients in the database. And what is important about this kind of databases is that you get real life data. We know that patients included in clinical trials are often younger, have less morbidity, and are more fit than patients who are treated in real life. And if specific treatments are registered and are given in real life, you want to know also the outcomes of real life patients. In this analysis, we ended up with 175 patients with complete data on treatment of metastatic uveal melanoma, and 67 patients were started with systemic therapy, 39 patients started with local therapy, and 69 patients were not treated at all. And here you see the outcomes of the whole group on the left upper side. All patients, the overall survival, then the patients with systemic treatment, which does not differ a lot from the curve for all patients. We saw that patients who had local treatments did better, and we know that patients with liver-directed therapies are often live longer, and the patients not treated had the worst overall survival. But essentially you see from this picture that up to 2018 we did not have a lot of systemic therapies to improve outcomes of uveal melanoma patients. Well, another curve or analysis in this database was that for prognostic factors, and we saw especially that LDH and the presence of liver metastasis were worse prognostic factors, and we know that also from, for example, skin melanoma, but in uveal melanoma, especially LDH high patients are really a group of patients which has a bad prognosis, and I think should not be considered anymore for treatment. Then another treatment outcome data set was the one in selected centers who treated tebentafusp, and that were 7 skin cancer centers in 2 countries, in Germany and Switzerland, and it was a real-life retrospective multi-center study. And on the right you see the progression-free survival of patients in real life with metastasized uveal melanoma receiving tebentafusp, and also the overall survival. And on this slide you see the analysis of patients who had immune checkpoint inhibitors first and followed by tebentafusp or tebentafusp first, and we did not see a difference. And this is very important because these real life data would not have been gotten out of the clinical trials, because in the clinical trial it was not allowed to have a first line other systemic therapy. And of course in real life we give immune checkpoint inhibitors to uveal melanoma patients with metastasis. So this kind of analysis in real life tell you more about the outcome in real life patients having other systemic treatments as well. And we are currently working on an analysis in 3 European centers for tebentafusp, and it is probably expanded to other European centers to have more patients in the analysis. In this study there were 78 patients, but we hope to get more patients in our European initiative to collect real life data on tebentafusp. Then another analysis in real life data sets which is important are the ones on toxicity, because we know that in clinical trials you have more fit patients having maybe less toxicity than in real life, in which older and less fit patients are treated. And what we saw in this paper is that the cytokine release syndrome was seen as much as in the real life or in the clinical trial, and also the same for skin toxicity, nausea and vomiting. So this kind of data on toxicity are especially important to also have the one data from real life as compared to clinical trial data. And then I did a last research on the current registries on uveal melanoma, and ChatGPT is very nice for that. And here you see the running trial or the running databases and registries which are running in several countries, which is good because most of these registries are either European or American or even more international to get enough patients and get enough data to say something about data in real life, but also on epidemiological data such as incidence. And then I come to my last slide. National cancer registries are preferred for epidemiological data, for example incidence, since national coverage is guaranteed. However, data are not always complete. For example, on follow-up, data are lacking of follow-up treatments and outcomes of metastasis. Real-life databases are of additional value for patient characteristics, predictive factors and outcomes outside of clinical studies. After phase 3 studies, efforts should be made to investigate the outcomes of new treatments in real life, either in phase 4 studies or registries or databases. And the incorporation of big data and machine learning algorithms are the future. And international collaboration is needed in the field of rare cancers to get enough data from registries and databases. And with that, I thank you for your attention. And I hope this presentation made it clear that we need registries to get enough data internationally, but we also need real-life data on new therapies to say something about the effect and toxicity in real life. Okay, thank you.